the coronavirus here, and if you are 50 years old above, you can go to any facility to get the injection.
Uganda has just over 1 million vaccine doses for a population of 40 million.
Corona kuliki kata. Bo deneta denagadi.
These AstraZeneca doses came from COVAX, the global vaccine sharing program. Uganda only started giving out its jabs 3 months after the US. Health workers like Benjamin and Dama were among the first to get vaccinated.
When COVID-19 broke out, I saw the nature in which people were dying. So I just felt in myself, I wish there was a vaccine. When today, I think I'm the happiest today that I've administered the vaccine.
Some of Uganda's first vaccines are going to people who aren't from the country, refugees from South Sudan, in part to avoid COVID ripping through a tightly packed settlement.
This is our waiting area, and the person will fill consent form from here, after which the person comes to take the vaccination, will come for the vaccination from here. What I like about my work is that I do something which prevents a disease, meaning the people I vaccinate are not going to be on the beds for my attention to treat them.
While countries like the US have managed to fully vaccinate nearly half of their populations, less than 1% of people in Africa's 54 countries are partially vaccinated. As variants spread, low-income governments are being forced to rely on wealthier countries to donate surplus vaccine doses through COVAX. Uganda received an additional 175,000 this month, but the next shipments aren't expected until August.
The world is in vaccine apartheid. As you know, high-income countries account for 15% of the world's population, but have 45% of the world's vaccines.
Dr. Alfred Triwale oversees vaccine programs for Uganda's Ministry of Health.
We have found ourselves in a situation where we do not have enough to give second dose to everybody who comes. Out of 22 million, if you vaccinate just below 1 million, this is insignificant. So the numbers we are vaccinating are too small to have any public health impact.
Countries like Uganda have been in limbo for months because COVAX depended on shipments from India, home to the world's largest vaccine maker. But the Indian government banned vaccine exports in the midst of its own outbreak.
The situation in India is complicating how quickly we can get those vaccines. Even without complications from India, what we know is the demand for COVID-19 vaccines globally outstrips the existing production capacity.
The chronic lack of supply isn't the only problem across the continent. In the DRC, low uptake forced health authorities to redistribute 1.3 million doses of the 1.7 million they received. In Malawi, a flawed rollout and lack of information led the Ministry of Health to burn nearly 20,000 unused doses. In Bidibidi, medical workers are also grappling with skepticism.
People ask questions when they come for the vaccine. They ask questions relating to their fears. Now, what if I get a serious adverse reaction and probably I die because of the vaccination? Will I be compensated? We need to go down in the community again. We really have to be there with them, listen to their concern, answer their concern, and give them the right information.
But even with better public information campaigns, experts at the World Health Organization say that in the best case scenario, some African countries will be able to manufacture vaccines by 2023.
This is not the first time we are suffering inequity. We saw this with the HIV. We are seeing history repeat itself. If by the time you get other countries vaccinating all their citizens, you get other countries opening the economies near full. And then there are others who are waiting to be hit by a second wave. Is that what people call injustice?